Good afternoon. My name is Jay Sackman. I'm a member of Advancing Excellence. I want to welcome all of you. I'm going to wait until I see that everybody has entered the room for the webinar before I begin. So I'll just give it 1 minute. Just waiting for everybody to enter the room. We're almost there. Okay, we'll get started. As I said when I first started, my name is Jay Sackman. I'm a member of Advancing Excellence, the Advancing Excellence in Long-Term Care Collaborative, and I want to welcome you to today's Spotlight Series, Managing Challenges Arising from CMS's latest guidance on psychotropic medications and behavioral health. The learning objectives for today's webinar are to recognize the updates to Appendix PP effective on April 28th, 2025, explain the importance of documentation of critical elements of behavioral and mental health treatments, develop a strategy to assist with prioritizing changes necessary to ensure compliance with the new regulations. This webinar will be facilitated and moderated by Chad Worz from the Executive Director of the American Society for Consulting Pharmacists. And before we start, there'll be some ground rules. Everybody who has joined the webinar at this point and who stays through until the end will be entitled to CEUs if you applied for them. And the CEUs that will be awarded in this webinar of 1 hour are Nurse CE Provider, and that's awarded by the Florida Board of Nursing. It's approved by the Minnesota Board of Social Work, the National Academy of Certified Case Managers, NAB for administrators, and approved also for pharmacists. A couple of other ground rules. If you have questions that you'd like to ask, please put them in the Q&A and they will be answered at the end of the webinar. It's important that you do that so that we can record those questions. Also, the slides will be sent to all of you, and the slides as well as the presentation will be on the Advancing Excellence website. So just a couple of minutes to give you a brief overview of Advancing Excellence. We were founded in 2006. It was initially called the Advancing Excellence in Long-Term Care in America's Nursing Homes campaign. We were funded by CMS and the Commonwealth Fund. And until 2010, we had registered up to 60% of the nursing homes in the country for the Advancing Excellence campaign. In 2010, we pivoted. We had run out of the grant funding, and we just started the Advancing Excellence in Long-Term Care Collaborative, which is a 501c3 organization. And we continue. Today, we have over 20 board members and several more members, and you were all invited to join. What we do is we meet on a monthly basis and have conversations about current issues and occasionally write white papers and send them to government agencies. We have many of the professional organizations and trade associations that are members, provider members, academic members, as well as a couple of companies that are members, one of which is very involved in today's webinar, which is Pathways Health. So at this point, I'd like to turn it over to Chad Worz, who will be the moderator of today's presentation.
Great. Thanks, Jay. And as mentioned, I'm also a board member of Advancing Excellence, and just a wonderful organization to provide just the kind of education that we're providing today as it relates to all of our work in the long-term care space. I'm a pharmacist by background, came to ASCP in 2018, and really work with the pharmacies and the pharmacists around the country that are working in our long-term care facilities. I am pleased to be joined today by one of our members, Will Hallett. He is the president and CEO of Guardian Consulting Services. Welcome to the panel, Will.
Thank you so much, Chad. I appreciate the opportunity to be here. And I agree, Advancing Excellence in Long-Term Care, the Collaborative, is an excellent organization, and I'm proud to be speaking today. Thank you.
And I'd also like to welcome Bill Vaughn, also a member, one of our health professional members. Bill is a consultant and has been a state surveyor in the past and brings a tremendous amount of experience when it comes to just how we try to interpret this guidance and to some degree the regulations that we face in long-term care. Welcome, Bill.
Thank you, Chad. Great to be here with you and ASCP and Advancing Excellence.
Okay, well, we're going to jump right into it. None of us have any disclosures as it relates to the content today, but we're going to jump right into, what we're facing. We had new regulations. New guidance to regulations. They kind of came in sort of a sputter. They were supposed to come last November, then they got delayed until January, then they got delayed until March, and then they got delayed until April. But on April 28th, this guidance came across, and it has some serious implications for those of us that work in nursing homes. So we're going to reiterate exactly what those changes are and have been. Consent being certainly one of those major changes, and obviously the continued emphasis on psychoactive medication. But I'll reach out to the panel. Do you want to just go over what are these big changes that occurred April 28th?
Will, do you want to start with psychotropics?
Sure, absolutely. So what happened on April 28th is the guidance to surveyors for FTEC 605, which had formerly been at FTEC 758. This was all the regulations at 758 on unnecessary drugs, which pretty much I'm imagining many of you in the audience are very well aware of. Everything on gradual dose reductions and PRNs 14 days and less, everything that you were aware of at F758 got moved back to F605. But at that point, they blew up the guidance to surveyors and for the most part rewrote it. Any of you that have read these things all know that the new language is going to be in red. It goes on for 17 pages of red. So there's a brand new guidance at this F605 on chemical restraints in particular. So we've got that. There are many sub parts of that I know Bill has some great expertise in, and we're going to talk about. There was some additional guidance on schizophrenia that was put out under FTEC 658, just as a general, that we're going to dive into a little bit later as we're talking about the breadth of these regulations and how they impact each of the different disciplines. One of the wonderful things about Advancing Excellence is we're cutting across disciplines here. And there is a lot for all of our disciplines to basically come together on and work as a team to solve and address and make sure that we are in compliance as best we possibly can. So as a brief overview, at F605, you've got everything going back to chemical restraints. Chad, you'll recall, when these regulations were first put out on unnecessary drugs, everything was about chemical restraints. To me, this is basically CMS circling right back to the beginning and going back to the roots of what the unnecessary drugs, particularly with psychotropics, was all about. So that's the brief overview of what we're going to be talking about at F605 and F658. And Chad, I know you're going to throw us some extra curveballs in there as well. So looking forward to that.
Thanks.
And I'll jump on to the end of that with a big call out in terms of the psychotropic guidance was a specific mention about a resident's right to be informed before receiving these drugs. And what CMS basically said was, hey, before you either start a psychotropic med or increase the dose of a psychotropic med, you have to talk to a resident who has capacity about the risk, benefits, and alternatives of doing what you're about to do with them. Now, that doesn't occur in isolation. There's an actual reg that has existed since the mega rule became into effect. So we're on year 7 out of that talks about what I would call informed consent, which is F552. And we're going to get into this in a little bit. But again, in terms of the updated guidance regarding psychotropics and informed consent, what CMS basically says is before you increase, you have to sit down and go over risk, benefits, and alternatives and allow residents to make decisions about whether they want to use these drugs or not use these drugs. And because of the nature of psychotropics, there's often a question about whether the residents receiving them have the capacity to make healthcare decisions. So part of the nuance to all this extends to when do you rely on the resident themselves, or how do you know whether they lack capacity, and when you go to the surrogate decision maker, and more importantly, the correct surrogate decision maker. So that's a big takeaway, but it's far beyond just psychotropics.
So I want to piggyback on what you just said, Bill. That whole concept of capacity and getting consent is extraordinarily important. In trying to look at the why behind this guidance and where this comes from, let's just take it from this point as a start. If you're going to get consent, that means that you're going to have a note on the chart or a consent form. A consent form is not required, but you can have one if you like. But whether you've got a note on the chart or a consent form, it's got to cover basically 4 key aspects: the risks, the benefits, as you mentioned, any reasonable alternatives, and then you want to make sure that any applicable black box warning has been discussed with the resident. Now, that can be done in the form of a note, and certainly if you a prescriber and you are going to deal with a resident and that resident has capacity, that's a little bit easier to do. If you have to chase down a family member, and not just that, but the right family member that actually has the authority to make the decision on behalf of that resident, that's going to be sometimes a lot more difficult. Again, let's now put this in perspective of why. Why is CMS asking to do that? Well, the obvious is everybody deserves to be informed of what treatments are going on to go. That's obvious. But I also thought of it in terms of perhaps CMS is asking us to really believe in what we're doing here. Like if you're kind of on the fence about whether somebody needs an increased dose or not, you're going to think it over before you're going to try to chase down a family with these phone calls running back and forth for half an hour, and then I called them, they called me back, and I wasn't available, and you're going back and forth. But if you really believe in it, if you say, all right, this resident has a bipolar disorder and their bipolar depression is really getting worse, the resident lacks capacity, I have to track down the family member. You know what you're going to do? You're going to do it. You're going to track them down. And I think that in some ways, this request for informed consent serves another purpose. It makes us stop, take a beat, think about what we're doing, and prescribe appropriately and only when necessary.
Yeah, I think great points, Will. It is very hard to operationalize this in a seamless, prompt way. And again, when we talk about all the other applications beyond psychotropics, it creates a real operational challenge for facilities to do it right. I've also been particularly interested in this FTAG since it came about, and have looked at deficiencies related to it. We're going to talk about what gets cited and what doesn't. But what's unique about this reg is how specific it is. Most regs generally say, look, if you come in without a decube, you shouldn't develop one unless it's medically unavoidable. This reg talks about very specific things you must do before going into interventions. And something I left out that Will just reminded me of, when CMS provided the guidance about psychotropics and consent, they specifically said you must talk about black box warnings. That's not, that level of specificity is not in 552, but it is in the guidance. And Will very carefully used a term, I think you called it relevant or appropriate black box warnings, right? Which I'm sure you're going to tell us more about when it comes to it, because I don't know, when I take my meds, and if I dare to look at the package insert, the black box warnings can be taller than I am, right? So there can be lots of them there. So we'll have to keep that in mind.
Yeah, I mean, when you think about black box warnings, particularly the warning of using antipsychotics in dementia-related psychosis, this is primarily a geriatric warning, but we know in some of our facilities we have younger populations. So just that one very simple example of where a black box warning might actually be there, but might not actually be something that would have to be discussed. So yes, it's the applicable black box warning. The other interesting thing, Bill, is that if you notice in the guidance to surveyors, it doesn't exactly say who is supposed to obtain the consent. And every facility that we go to, me and my team, this is one of the ongoing discussions. If psychiatry is prescribing it, is psychiatry going to do this? Is this an extender? Is this a nurse? Is this the medical director? Is it the attending physician who might have to sign off on this order before it goes into place? And I don't think that there's any one right answer except to say it should be somebody that is competent in two things: the 4 points of information, the risks, the benefits, any reasonable alternatives, and any applicable black box warnings. And then they've got to be also competent in and confident in why the drug is being prescribed. Because in effect, you are selling this now to the resident in terms of, we believe this is in your best interest. And if you don't sell it properly and they turn it down and a negative outcome comes of this, well, then nobody wins.
Yeah.
So we've got that issue as well.
Absolutely. And, you know, in this very narrow band of psychotropics, I'm not sure the average nurse, LPN in a nursing home can meet the criteria you just talked about. I mean, would every nurse know enough to sit down and have an informed discussion? Particularly, what about alternatives? Are you going to talk about lesser risk drugs? You're going to talk about no drugs? And again, something we haven't said yet that's going to come up tons is this term that is pivotal now. It's always been big, but non-pharmacological interventions are the cornerstone of all of this. I would argue that, you know, we're talking about drugs here, we're talking about schizophrenia and informed consent. Let me tell you, before you give someone a drug these days, particularly in the realm of psychotropics, if you don't have good documentation in the medical record that you attempted not just a single, but maybe multiple non-pharm approaches, or very clearly say why using a non-pharm approach would be clinically contraindicated, this guidance says just that lack of documentation makes the drug not appropriate. It is,
yeah, I mean, that's the key point. Simply failing to have that documentation. Now, I mean, look, Bill, you're a nurse. You know what nurses do by knee-jerk reaction if somebody has a newly emergent behavior. What do? They take the resident to a quiet area. They dim the lights. They turn down the sound. Maybe they're just overstimulated. Maybe they're simply hungry. Did we give them something to eat? Are they in pain? They check them for pain. Do they need to be toileted? They separate them out from other residents. They bring them to a quiet area. Nurses do all of this by knee-jerk reaction, but do they write it down? So again, you're right. You're shaking your head no, because unfortunately, in the midst of doing all of that, you've run out of time. You know, when are you writing this down? You're not going to say to the resident, listen, you just sit there for a minute. I gotta document this all out. No, you're trying to calm the resident down. So what we're trying to instruct our facilities, and what I'd recommend for the audience is that when you consider these notes, yes, these things have to be done prior to initiating a drug. And it's entirely appropriate to try these things, but a late note still counts. And it's really important that if you know that this person was tumbling out of control, they had a bad Thursday morning, which turned into a worse Thursday afternoon, and now we've tried everything we can and we're reaching out to the prescriber, we're going to get a drug prescribed. That's fine. You know, they've tried everything they can. This person in most facilities is going to end up on shift report, which will go to 24-hour report, which will go to morning report. When this person shows up in morning report, my advice to every facility that will listen is the minute they check in for morning report that they've had a change in behavior and a new drug was prescribed, somebody needs to go back and check to see, were the non-drug interventions documented? And oh, by the way, Bill, everything that you said before, is the note on consent there? And again, same concept. Late note still counts.
I couldn't agree with you more. Underutilized, and people feel like writing a late note is somewhat sleazy. It's not. It's perfectly reasonable. Yeah, I think most people associate non-pharmacological interventions with PRN drugs. That's not what the reg says. The reg says if you're on a psychotropic period, you have to be given non-pharm to get the dose down or eliminated, right? So keep that in mind. And again, I think that leveraging activity staff, therapy, dietary, all kind of stuff can help with non-pharm approaches. But Chad, that was a long-winded answer to your question.
Oh, that was a great overview because I think it really elucidates to everyone, what are we talking about? How are we approaching this? Particularly the late note. The two things I wanted to bring up was, I think as far back as I can remember working in long-term care, documentation, 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 and not only documentation by the nurse, but the consultant pharmacist, the prescriber, the nurse. Not only does it have to be there, but there has to be some level of alignment with it. I think that does a lot in protecting you from what a surveyor may find when they're in looking around the chart with respect to all of these regulations, all the regulations, to be honest. And again, I think somebody brought up time. There isn't a lot of time, but it's so important to take some time and document things like that. Talking about the morning report and overnight, leads to the biggest question I think we've gotten, which is, what if someone has a psychoactive crisis, psychosis in the middle of the night? They have to prescribe some psychoactive medication. You're not going to be able to get consent from the family in the middle of the night. You have to do what you have to do, short of saying, well, we can't get consent, let's send them to the hospital. You have to do what you need to do, get them the right treatment, therapy. If non-pharm is the answer, great. If it's not and you need to use a medication, great. You can still go have that consent conversation the next morning for something that already happened. I mean, there's no other way to deal with it.
Right. Best interest of the resident is what the test is, right? And again, getting back to the specificity of 552, I mean, it's very clear. Before you do something, you must get consent. It's not maybe, it's clear. However, this is a great example of do you follow the letter of the law or the intent? And the intent of meeting the needs of residents, the best intention is the way to go. And Chad, I completely agree with documentation in terms of being the path of least resistance, keeping surveyors from second guessing what you did 6 months ago in the chart. But I have to say this, that none of us will ever document enough. It doesn't, the perfectly written chart does not exist and won't exist, which leaves us to do what happens when a surveyor picks up a record and has legitimate questions based on what's in the record or not in the record sometimes. So I have to say that it is important to be able to talk to surveyors and regulators about what the record says and at times what it doesn't say. And I'm not suggesting at all that people stretch the truth or change perspective, but I think you have to, as DONs and administrators and medical directors, talk with staff about what's the right approach to deal with a lack of documentation. And oftentimes that's an honest discussion with a regulator about, this is what happened. I remember it like it was yesterday. This is what we did. I'm not saying that's going to work every time, but I'm saying there's not a whole lot of other options to look at. And one good thing is the guidance to surveyors throughout all the regs pushes surveyors to talk to residents, to staff, to family members, not just rely on the medical record. And I think that's healthy, although many of people on this webinar are probably shaking their heads going, it's never going to happen. No surveyor is ever going to believe me if I say it's not, I did something that's not in the record. But I think it's important for all of us to recognize that the record is one-dimensional and life is not one-dimensional.
Yeah, and I think the other aspect of this that I was going to bring up was with respect to non-pharmacologic interventions, because it's a point of emphasis in the guidance. You have to think of it not, and I loved how you presented it as, it's not a PRN. It's the diet and exercise that goes along with the cholesterol drug. The cholesterol drug is going to work. It's going to lower your cholesterol, but that doesn't save you if you don't do the diet and exercise part from the risks of cardiovascular disease. And I think the same thing is true with respect to non-pharm interventions. Yes, there may be some great non-pharm interventions for behaviors. It may allow you to not use a medication for an individual, but even if you have to go to use a medication for an individual, that doesn't mean we don't do non-pharm interventions anymore. Right. It should be part and parcel to their care plan. It's and certainly individualized to that particular resident, and it can include all the things that you guys described. It's Did we take them to a quiet corner? Did we dim the lights? Did we make sure that they didn't have pain or need to go to the bathroom? Do we have appropriate activities for that particular resident? All those things arguably count if you compose them in that documentation on your plan of care for somebody on a psychoactive med. And I think that's important to bring up as well for everybody out there. Because those are the big, red flags. What's going to get us in trouble? I think getting you out of trouble is making sure that you manage those aspects fairly well.
Yeah, I think a lot of us are somewhat nervous about what you brought up before, Chad, is those true emergency situations. And Bill, you were referencing this a little bit. It's not as if if you've got somebody with a severe break in their just a psychotic break going on, and they are a clear danger to themselves. There's plenty of other places in the FTAGs that require us to act in a manner that ensures the safety of the resident and others. But the bigger thing is that there's a practicality issue here, and then there's that concept of clinically contraindicated. Let me hold that for a second. But it's not as if you can look at somebody and say, okay, listen, I know you're about to, you're at the window, and I know this is a very dangerous situation, but I got to get you lumped. You can't do that. There's a practicality about this that just doesn't make any sense that we have to put in perspective. However, there is some verbiage in there, verbiage in there that allows us a little bit of wiggle room, and that's in this whole concept of clinically contraindicated. So you want to try these non-drug interventions, but you can't try all of these things if it is a true emergency and somebody is in clear and present danger, and the staff is in clear and present danger. You have to do what you have to do in the immediacy of the moment. What I've been trying to work with our facilities on is, in the immediacy of the moment, you do what you need to do. You certainly inform the family, the responsible party, and if you are going to continue to treat, then the consent absolutely comes into play. You get your consent and you make sure that you have that. You do what you have to do in the heat of the moment to ensure the safety of that resident. And if you're going to give doses going forward, you're going to now make sure that all of those consent and other pieces of documentation are in place.
Absolutely.
One other thing to jump in on this is, if you actually read carefully, the other thing that CMS is asking us to do through this guidance is make sure that if somebody is tumbling out of control, that we don't just try our non-drug interventions, have those fail, and then we throw a drug at them. They're also asking us to really be good clinicians. They want us to go back and do the appropriate medical workup on that resident to see if there is a medical driver. And the reasons for this, when you think about it in that context, are actually really obvious. If I find out that, let's say it's me and I've got a bad liver, my ammonia level's through the roof, or somebody treats my high ammonia level, my behavior straighten out, you eliminate the use of the antipsychotic or psychotropic medication much faster. And so that's what they're after. And the medical workup that they're asking for really has to be appropriate for the resident. Resident's diabetic. Did anybody do a finger stick? They're 79 pounds and 99 years old. They've been sitting by the window. It's 100 degrees out today. Did somebody just check to make sure they aren't dehydrated? There's infections. Oh, heck, we could do this all day long, right, Bill? We could literally bounce reasons for an acute delirium back and forth all day long, but we have to make sure that we do that.
And the behavior issues, I mean, many people, social workers on here are going to say behaviors or communication. That's how people who can't tell us what's wrong, tell us what's wrong. So a part of it, again, as Will just said, is trying to get to the bottom line of what the behavior is demonstrating, not just getting rid of the behavior.
Yeah, and that was the last thing I was going to bring up, is just thinking about sort of safe harbors that we have in the nursing home. Safe harbors, like, are we really good at making sure we document behaviors, not only from the perspective of the survey process, but it tells us whether or not an intervention is working, whether it's a non-farm or a farm. If somebody had 14 episodes last month and now they have 3, what did we do to achieve that, and how are we maintaining that going forward? Same thing with safety. Are we making sure that we have good documentations? And this, I'll point to my folks on the pharmacy side. Are we documenting safety screenings? Are we making sure that the medications, if they are being used, we're not running into problems with side effects or problems? I mean, those are safe harbors. Are we getting to the point, you talked about diagnosis or being detectives about what might be the root cause of the behavior, but are we doing a good job getting to the diagnosis? For a long time, and I think we're much better at it today than we were, dementia was a giant category. Like, this person's demented, they have dementia. Now we know that there are all kinds of different kinds of dementia. There's all kinds of different kinds of psychosis, and there are specific treatments and therapies that can be used for those specific conditions. So if we're doing a good job doing a plan of care for an individual patient, we're identifying what they actually have. We're documenting. No, they don't just have psychosis, they have Parkinson's disease psychosis. And we're
Correct.
getting the right FDA-approved medications on board. Those are all sort of safe harbors that people can use to protect themselves, but also to get to the right treatments and care for the patient.
Chad, we're half an hour into this webinar, and
I
I'm
know.
telling you, what we've talked about is process. No one on this webinar can guarantee a good outcome.
Right.
What we can guarantee, what we have control over, is our process. And so all the stuff that Will has talked about and you and I have talked about is what should a good process look like? And I think that's what regs should expect of people, is doing a good process. You cannot guarantee the outcome, but you do have control over the process that gets us there.
Yeah, I mean, I was consulting when we started to do behavior management meetings, or specific meetings in the nursing home beyond the QA meeting where we focused on mental health and behaviors. I think that's probably pervasive. I probably would argue everybody does that today. That was a movement in process. And what I liked about it was interdisciplinary. We were creating some documentation around that meeting that was specific to that patient. And it was in some way a way of sort of dealing with all of this guidance around these particular regulations. And again, I know that's probably something everybody does, but I think just emphasizing that's part of this process that we do to try to make sure that we address this guidance appropriately. All right, I'm going to jump. You're right. We're 30 minutes in. I want to jump to the next question, Bill, because I think it's interesting. It's only been 2.5 months. We know that the data on surveys in that 2.5 months is going to trail. But what have we seen? What's out there maybe that we've seen in the first 2.5 months that gives us any sort of direction to what we should be thinking about in our nursing homes?
Yeah, so go ahead and advance the slide one or two times, Chad. As Chad just said, the current survey findings don't really tell us much yet. They just the guidance became effective at the end of April. It's now mid-July. There's upload times, there's lag times in terms of getting survey data up. So there's not a whole lot we can glean about what did the recent guidance mean in terms of deficiencies. However, as we said, the guidance is new, but the regs they're based on have been there since the mega rule. So we did take a look at some of the guidance, some of their current deficiencies, and I think I want to share with you the ones that I think it's important for you to hear. Next slide, Chad. I think that I want to talk about informed consent for a minute, and I'm going to say something that's going to be unpopular with many people, but I want to tell you what the reg actually says. And while the new guidance that CMS came out with focused on psychotropics, the reg itself talks about treatment, that before you provide treatment to residents, and let me tell you how treatment is defined. I actually wrote it down. It's incredibly broad. So treatment is defined as medical or nursing care or interventions that maintain or restore health, improve function, or relieve symptoms. I would argue that not much you do every day doesn't meet that definition. So when you look at this reg beyond just the psychotropics, I can tell you that I looked at deficiencies recently. A facility was cited for failing to have an informed consent discussion regarding bed alarms because of the perceived risk of, if someone has a bed alarm, it may limit their mobility, leading to skin breakdown and isolation, that kind of stuff. There was a particularly interesting one where a facility had suddenly lost a lot of their on-site therapy staff, and they were a large provider of acute rehab, and they continued to admit people, but only provided therapy via Zoom, not in person. And so they were cited for failing to provide informed consent that, hey, if you come to our facility, you're not going to get a hands-on therapist, you're going to get a Zoom therapist. We can argue whether that's even right or wrong, but there is a lot to informed consent beyond just psychotropics. I would encourage people to look at the actual language of the reg and then look at the definition of treatment and start thinking about other things. When I have conversations with my facilities, it's not just psychotropic, because what happens at 11 o'clock at night when someone spikes a temp, has a cough, you get a chest x-ray, it's positive, and the doc orders Cipro. What do you do before you give the first dose of Cipro? And are you required to go through the same process as we are talking with psychotropics? I think the answer is yes. And so lots of stuff to look at. I'll tell you what gets cited in terms of informed consent that get people in trouble, and that's not following your own policy and procedure, a favorite of surveyors to cite, right? So whatever policy and procedure you currently have around obtaining consent, make sure it aligns with the reg, and make sure that you're not being so specific that it's unmeetable, which is often the case. Decision-making capacity is a big one. Many deficiencies I read recently are going to residents who are otherwise not allowed to make choices about their healthcare because they've been deemed to lack capacity. But now someone's going to them to say, do you want to take the psychotropic drug? Similarly, if a patient lacks capacity to make healthcare decisions, our facility is going to the correct legally authorized decision maker. You know, the daughter who is very loving and active and at the nursing home every day may not be the legal decision maker. And so it's important facilities to, one, have a process in place where you kind of on an ongoing basis look at whether people have decision-making capacity. And if they don't, look at who you're going to go to make decisions. Let me just say this last one that I call survey overreach. So I've seen under this tag for years these kind of deficiencies. The facilities get cited for, during a med pass, the nurse giving the med not going through the risk, benefits, and alternatives every time they give a pill. I don't believe that's the intent of this reg. I don't think it's the standard of practice, but I can tell you that it does get cited. And I'm a pretty big advocate of talking with surveyors and helping understand where you're coming from on this. And if that doesn't work, using both the informal and formal dispute process. And people like consultant pharmacists and medical directors are great at this. But again, this to me shows what happens when our new guidance is put in place. Sometimes surveyors, there's a learning curve, and some surveyors take a while, and survey agencies take a while to catch up to what we're really trying to do. So as we're talking about this, if you get cited under informed consent, take a look at the language of the reg, the definitions, and see whether or not what you're being cited for is meeting the reg or the standard of practice.
Yeah, and I would, again, for all my pharmacist colleagues out there, I'm sure will reiterate this. Being available during survey is important when you're the pharmacist, when you're the medical director, for just that very reason, because I think you have to be able to dialogue with that surveyor if there's a concern that the surveyor is overreaching. They have to talk to the person that's responsible at that nursing facility for either the medical care or the pharmacy or the medications, in order to be able to push back a little bit and say, hey, I think you're looking at it from the wrong perspective, or you're overreaching a little bit. And when you have an expert in there at your disposal, use
Right.
and engage.
Yeah, no doubt. You have surveyors that, even if they're well-intentioned, might be expressing opinion as opposed to regulation, and that's fine. But if we're meeting the intent of the regulation and we have the expertise in the area, we should be available. I completely agree to make sure that that we can have those conversations with the surveyors and then follow up with the ancillary departments, whether it's the medical director, the director of nursing, the administrator, social work, any other department that might have been touched by the conversation, so that we're all working off of the same, not just necessarily script, but fact pattern.
Yeah.
Here's the facts that we dug out, and that we discussed with the surveyor. You should be aware of that if you're going to have a conversation with a surveyor. But getting back to what you led this off with, Chad, you're right. It's only 2.5 months that this has been in place. We know that there's not a lot of data out there for us to basically latch onto and say this is the direction the surveyors are going, and that boxes us into a corner of having to basically predict the future, look at the guidance and try to see where it's going. And I will tell you what I see when I read through F605, thoroughly, and go over it, and I talk to people about it. They keep going back to this concept of not just chemical restraints, but and used for convenience and discipline, but they mention oversedation multiple times as an indication that we're misusing the drug, even if it's an approved indication. Are we monitoring the drug? And the way I've been describing it to people is, depending on whether your building is very vertical or it's lateral, you get a very vertical building. I call it the step off the elevator method. You step off the elevator, it's 10:30 in the morning. You see a resident that's in a chair and they're sleeping. It's 10:30 in the morning. Why are they sleeping in a chair? Okay, if you were a surveyor, why wouldn't you say that chart is now part of my sample? Let's see if that person's on a psychotropic, and literally just pull that person into your sample if they weren't already there. And at that point, now you've got a series of discussions that has to happen. Okay, well, they always nap at 10:30 in the morning. Well, now why aren't you doing resident-centered care to give them a better environment to sleep in? Even if you can argue your way past, the fact that they're doing, that they're not over medicated, that it's, appropriate use of the psychotropic that they're on. The other things that we really look at is, we try to focus with all of our facilities is low dose antipsychotics, trying to bring this back to the very, very practical. If you look at the package insert, say on risperidone for schizophrenia, it will suggest that you need 4 to 8 milligrams. Well, what are we doing with a 1/4 milligram of Risperdal at bedtime or 25 of Seroquel at bedtime? Are we truly treating a medical psychiatric condition? Or are we just giving them a low dose at bedtime in lieu of a sleep medication because of staffing concerns? And does that not qualify as convenience of staff? Now, what I stress to everybody as I'm talking about this is, it doesn't mean that every low dose at bedtime is inappropriate. Could be completely appropriate. Again, we've got the other side of the regulations that requires us to find the lowest effective dose, correct? And you've got plenty of people that you're trying to minimize the side effects. There's going to be some sedation. Let's take advantage of that and give it to them at night. There's going to be an increased risk of falls. Let's give it to them at night so that they're less likely to be ambulatory. Maybe they're having night terrors. There could be any number of good reasons, but it's a good place for facilities to start to try to investigate where they might be at risk for upcoming, surveys, where they might look. As a practical thing. One last practical thing before I kick it back to you, Chad. We should be looking very carefully at the diagnosis that we're putting in the actual order, not what's in the consult, not what's in the progress notes. What's in the text of the order is, if you say in the order that you're using that drug for restlessness and agitation, that sounds like convenience of staff for me. That sounds like I'm not doing my drug, my non-pharmacologic interventions. It sounds like I'm simply using this drug because this person is restless or agitated. Is it discipline? Is it convenience of staff? And why should the surveyor look any further than that? You told them, you signed off on that 12 months in a row, that's what you were using it for. So looking at the actual diagnosis and making sure that it matches across to the physician or the extender's progress notes, that it matches across to, if you're lucky enough to have psych consults that are in place, and making sure that it matches and it makes sense is also a key thing that we should be thinking about under FTEC 605.
Yeah, and I'm glad you brought that up because again, just the concept of some of the medications that you brought up, the quetiapine at bedtime, it's so important that you provide the documentation and rationale for the medication that you're using. And I like the way you present that as even including the order that's written for the medication, not putting the symptoms in the order, but putting the diagnosis in the order.
Correct.
If you have agitation with Alzheimer's disease, there's now an FDA-approved drug for that. Like put that in the order. That helps you on the documentation side, from the perspective of what a surveyor might look at. I mean, it gives you some, it's easier than having to explain in long form, why did you pick this drug or why are you using this dose, which becomes challenging, I think, in some of those environments if you're not paying attention to that. So I think that's important. But before, I know we probably have 1,000 questions. I want to remind the audience, use the QA function because we can capture those questions. And if we don't get to every question, which it's unlikely that we will capture those questions and get everybody a copy of some of the answers to those questions. So use the QA function. And then I wanted to just talk briefly because, in between planning this webinar, executing this webinar, in this particular administration, we wake up every day to something new. And something new occurred a couple weeks ago where CMS is changing how they're going to measure the antipsychotic metric. They're going to start using Medicare claims data to compare to MDS data. And they're also going to use what they call encounter data, which is physician and nurse practitioner level data that indicates, what the diagnosis is or should be. And they're using that, I think, in a frame of trying to get at, this issue with schizophrenia. Is it really schizophrenia or not? And I know that both of you might have had some comments with respect to that because it is a targeted survey right now to look at schizophrenia and make sure that people aren't just using that diagnosis as an out for using an antipsychotic. So I wanted you to comment on that, and then we'll kind of open it up to questions.
Sure. So regarding the schizophrenia focus, MDS focus audits that have been going on, many of you that are listening have probably, had some experience with this or know somebody that's had experience with it. I've been involved in far too many of them. And they are very intense and they are very, very focused on making sure that if you are going to code, the MDS people are going to code I-6000 schizophrenia in that MDS, and they're going to report it, that it is meeting diagnostic criteria as published in the DSM 5th edition for schizophrenia. That means the person has one of the big three: hallucinations, delusions, disorganized speech, along with other signs, symptoms that would be consistent with schizophrenia, that it's been more than 6 months of this continuous, and there are no medical drivers that would explain it. I could have hallucinations, could have nothing to do with schizophrenia. So that's basically where it's going. Ultimately, Chad, the really interesting thing is that not only do they want to make sure that MDS is doing this, but they put this under the comprehensive care plan tag F658. Everybody listening to this knows you do comprehensive care plans on a million different things. However, the entire tag, all 7 pages, deals with schizophrenia. That's what that tag is about. I would encourage everybody, pull out the updated F658 guidance, read all 7 pages, understand where that is, and make sure that you're working very carefully with not just your MDS people, but also the comprehensive care plan team that should be evaluating the notes from your medical director, from the attendings, psychiatry if you have it, to make sure the person is meeting professional standards for the diagnosis of schizophrenia. This is an ongoing focus. The interesting thing, Chad, cross-referencing all of that claims data. What are the clinicians saying they're seeing the resident for, as opposed to what we're coding? And that's going to lead to some very, very interesting stuff. And CMS has already come out and said, look, it's about 14.74, I think, percent of the population is in nursing homes is on antipsychotics in the absence of schizophrenia. They're saying this is going to go to 16.98 on the October 29th update. They're already predicting their own future, which means they've already analyzed the data. They already know that the claims data doesn't match what's being submitted by the clinicians versus what's being submitted from MDS. So they know there are mismatches here. So I would double down on this. This is an issue that's not going away. It is important that if somebody truly has schizophrenia, we document it. And if they don't, we don't label them as such.
Exactly. Bill, any comments on that?
Just quickly, the term diagnosis, I get asked all the time. What's a permissible diagnosis to use this drug? The regs, that's an urban legend. There is no permissible diagnosis or or one you can't use it for. The devil's always in the details, and I would caution people that a diagnosis by itself doesn't buy you the use of any drug. It's take a big picture look at the resident, what their needs are, and go much beyond the diagnosis. But there is no hard, bright line on, yes, you can use it if it's this diagnosis, and no, you can't if it's not.
Okay, well, I am going to stop sharing my screen and take a look and see what kind of questions we have in the QA. And as anticipated, we have quite a bit. I'm also going to turn it over to Jay Sackman to come back and kind of lead us through the QA process. I have to actually drop, but thanks everybody for listening today to me, and certainly thanks to our panelists, Bill and Will, who are just unbelievable experts at this. Thanks for sharing your expertise. Jay, I'll turn it over to you.
Thanks, Chad.
Yeah,
Thank you, Chad.
Thank you, Chad, very much for putting this and for moderating, for putting this together. So we're not done yet, so I'll give Bill and Will an opportunity to look at the questions and see if there are any there that there have not been already answered. I know I've been going through them. There are about 30 of them so far.
Yeah, I'm seeing a lot on informed consent here. One that popped up, can you clarify if informed consent legal document is required? And the answer to that, basically, Anna Meyer, thank you for the question, is no. There is no specific requirement that you have a form, just that there is a note on the medical record that says that prior to initiating an antipsychotic drug or increasing a dose, that you've addressed those four key aspects: risks, the benefits, any potential alternatives, any applicable black box warning, and that the resident or the responsible party gave consent. There was a follow-up questions that basically said, what if you can't get the family member in the middle of the night? And again, acting in the resident's best interest. I think, Bill, you did an excellent job of detailing that out.
Yeah, that's not a hypothetical. It happens all the time, right? There's times, again, if we get away from psychotropics only, plenty of drugs get given on off hours when the surrogate decision maker is not available. So I would argue a couple things. One is address it in your policy and procedure. What are you going to do when the choice comes? Do you give the drug or do you wait for consent? Don't leave that up to every nurse on the floor to decide. Put in your policy, and of course keep the prescriber in the loop about it. I completely agree with Will. There is no requirement for written consent. Many of the states you're in may have state regs that require written consent for psychotropics, but from a federal standpoint, that doesn't exist. As a risk management perspective, I'm not a fan of written consent. I don't think people understand them and read them anyways. However, if a surveyor walks in and says to a resident, I see you got an antibiotic 3 months ago. What did the staff tell you about the antibiotic before you took it? They didn't tell me anything. Well, the record's going to show that a risk benefit and an alternative happened. And in that same resident, they now have C. diff. And no one told me I could get bad diarrhea from an antibiotic. A written consent would cover you from a risk management standpoint a little bit better than the note in the record. Again, I have trouble even saying it because I'm not a fan of consents, but from a strictly risk management, having a signed consent probably is in a facility's stewardship best interest.
A couple of back-to-back great questions from Mary Padama. Let me just read them for the audience here, and then we'll see if we can answer them. Mary writes, can you use the informed consent from the acute hospital when the resident is transferred? If not, do you wait to start the medication until you can get consent if the resident does not have capacity? And then following up with that, if the resident does not have capacity and there's no family, common question, what do you do here? So I've got a couple of thoughts on that, Bill. I don't know if you want to jump in with a couple of thoughts there, and then I'll give mine.
Well, if you think about it, that the age-old question of can you rely on what the hospital sends you? That presumes the hospital went through an informed
Yeah.
consent process before they gave the drug. And, let's not bet
Yep.
your house on that one. So I think it is risky. Once you own the patient, once they're admitted, you're saying, I'm going to give you this drug and I know that you consent to it. I think I'm not going to be able to give you a direct answer because the regs don't answer directly, but I think relying on the hospital to have done the informed consent discussion is problematic in a number of ways. And I think we all know that. And again, not being able to get a hold of somebody, not having anybody to get a hold of. The question now becomes, do you need guardianship to give Tylenol to somebody because you need informed consent? I don't think so. But the way these regs are written, I often think with my facilities, how would I defend it if they got cited under this reg? And to be brutally honest with you, the way this reg is written and the definition of treatment, it is hard to defend if a surveyor wants to take us an extreme position. But Will, help me out here.
Yeah, sure. So let me jump in on this a little bit, because this question has come up very often. The reality is that if the drug was started someplace else, we're not the ones initiating or increasing the dose. So theoretically, and again, as you point out, Bill, this is very theoretical. Somebody else already had that discussion. My impression is that we don't have to have a consent note for for a continuation of therapy, whether it's an antipsychotic, psychotropic, antibiotic, or anything else. However, that doesn't mean that it's not a wise idea to actually go back and do that. In terms of what about the resident that lacks capacity and there's no family member, facilities should have their internal mechanisms for dealing with questions of delivering care and making decisions on behalf of that resident, whether it's an ethics committee, whether it's a 2PC situation where two physicians get together, whether it is some other team within the facility that now makes a decision on behalf of that person. Whatever your process is, I would wrap this into that existing process. I'm being told, Bill, that we have 2 minutes left. Let's see if we can pull out one more good question here.
As you're looking, Will, we had a comment, or one of our last slides was
Sure.
Quality assurance and best practices regarding all we've talked about. I would just say this, that QAPI is huge in this whole process. And because of all we've talked about is really process steps that you need to take to effectuate compliance with these regs. There's lots of steps you can monitor. I'll put a plug in for age-friendly health systems and care and the 4 M's that have been pushed by the Hartford Association, I think Advancing Excellence, and I know ASCP. Much of the 4 M's and age-friendly care align with absolutely everything we're talking about, not only to maintain compliance, but frankly, to do the right thing in caring for your residents. So if you're on the fence about being part of the movement, I would become part of it. If you don't know what I'm talking about, just Google age-friendly care or go to ASCP's website and they'll have lots to share with you on that.
One last thing for me before we wrap up. This is a comment that comes from anonymous attendee. I would love to give you credit, but it's just showing up as anonymous attendee. We get a consent for increase and decreases in psychotropic medications, even though the regs for these meds say for increases is for the increases basically, and New Start is where it's required. And it's not technically needed for a GDR. So I'm paraphrasing here a little bit. I would suggest that this is correct. The regulations to take a drug dose down, you don't have to get consent to reduce or eliminate a potentially unnecessary drug. However, that does not mean that in all cases you wouldn't want to talk to the family to let them know what's going on, because we know how certain families are. And you want to make sure that they're aligned with the care that you're giving. And in some cases, they might actually have some information that might sway the medical judgment as to maybe we're not going to do a GDR now because you have them at home and you've seen what the failed GDR looks like there. And so while that's possible, we also have to be mindful that the family also has no right to dictate medical care. That if you need to take it down because the person's suffering from a side effect, you need to take the drug dose down. And if the family is fighting you tooth and nail on this, this is where we rely on the team. And you go back to the administrator, the assistant administrator, the social worker, the entire team, and work together to work with this family member.
Agreed.
Jay, anything last for us before we wrap up here?
Well, I want to thank both of you and Chad for the work that you put into this. I've been on all the email threads going back and forth about what the content would be and meeting the learning objectives, and I think you did a great job. And I can tell from the questions that a lot of people were paying attention. I could also see that we still have 650 people who are on the webinar. I want to make sure that everybody knows that you will be able to view the webinar, also receive the slides on the Advancing Excellence website. They'll be up there in a few days, probably within a week. We'll have everything up there. And if anybody's interested in joining Advancing Excellence, we have slots for organizational members like the American Society for Consulting Pharmacists. We have provider members like AG Rhodes and Sabre Health. We have supporting members like Matrix Care and Pathways Health, and individual members can join. All the information about joining, what the membership fees are available on the website. I think it's a very informative website, and you can go back to previous webinars and download the presentations that were made in those previous webinars. So, both the voice, the webinar, as well as the slide deck. So thank you again, all of you, for participating, and Pathways and Tekla for putting this all together today. And we'll be signing off now. Okay,
Thank you.
Thank you, everybody.
take care.